Welcome to Health is Wealth. My name is Roberta Robinson. I'm Director of Marketing and Outreach for the Geriatric Division of the Cambridge Health Alliance, as well as the PACE program. And today I'm excited to have with us Dr. Murtuza Vali. And Dr. Vali is a geriatric psychiatrist. Welcome. Thank you for coming.
Hello. Thank you for having me here. It's a pleasure to be here.
Oh, it's a pleasure to have you.
Thank you.
So we are... today we're going to be talking about mental health wellness.
Yes.
Basically, we know how to keep our bodies healthy.
Right.
We know the drill. You know, they tell us, eat healthy, exercise, do all that.
Yeah.
So how do we keep our mental health well?
As you know, in today's lifestyle, we have so many things to do in day-to-day work, school, professionally, leisurely. To keep all of this, well balanced, we do have to have a decent sleep-wake cycle, a good sleep schedule. Part of it is also eating balanced, healthy diet, and exercising. If you find time, typically regular exercise, hopefully aerobic exercise like 10 minutes daily would be ideal. But a lot of people cannot keep up with that. But even if you
or a lot of people can't do that.
Can't do that, right?
Because they're
right.
physically not able. They might be on walkers or canes.
Exactly.
Or
Yes.
physical mobility
Yes. If you
issues.
have, yeah. So even if it doesn't involve physical activity, maybe even like socially interacting with like a peer or someone who a family member, oftentimes is much relaxing and anxiety relieving for a lot of people. It does give them a sense of hope, sense of collegiality with other people. A lot of people find reading magazines, watching TV also stress relieving.
I don't know. TV today is not so stress relieving.
Yes, that's right. The news.
How about calming music?
Calming music, yes. Coping skills such as relaxation techniques and listening to calming music is helpful. Especially people should have a regular sleep-wake cycle. I mean, that should be something that I think would promote mental health well-being.
So that's an important point that you raise, because as I am out here in the field,
Yeah.
I find there are an incredible amount of people that
Mhm.
have sleep problems. And a
Yes.
lot of them have that sleep apnea.
Yes.
Then they have to wear that mask. And
Right.
that can't be too comfortable anyway.
No.
So what is that, first of all? Why don't we explain that to the people?
So CPAP, the machine itself is called CPAP machine. It's actually continuous positive airway pressure machine. It's used in patients with obstructive sleep apnea. Apnea is lack of breathing for a limited time, or actually it could be any time frame. Typically lasts from a few seconds to 10 or 15 seconds, but that is actually scary because a patient in the middle of sleep actually just stops breathing, stops inhaling and exhaling, and it's usually caught on by during a sleep study, where someone can, when the sleep study documents the lack of breathing that has actually happened while a patient is not even aware of it, and has stopped breathing, which actually can drop oxygen levels in the system. So what the CPAP machine does is continuously give a pressure. It's a non-invasive mask. It's not a tube down your throat. It's actually a mask on your face and nose. It's strapped. I think there's a strap behind, that goes behind to keep it stable. And most of these nowadays, the new machines are pretty silent. They don't make a lot of noise to wake up the partner.
So is it oxygen?
It is actually airway pressure. I don't no, it's not, I don't think it's oxygen. It's just regular air, I think, but it's continuously breathed in. So yeah, I'm not really sure if it's oxygen, because the oxygen cannula is a different kind of an inhalation technique.
I know.
Yes,
right.
the nose, so.
Right, but I wasn't sure how it worked to keep the person breathing.
It's actually, it's because you're not expected to, because the patient who is actually in the middle of an apneic episode is actually not inhaling
Yeah.
and exhaling like we usually see them doing during the daytime. In the middle of sleep, they don't do that. In a positive air, with that machine, there's a continuous pressure. So even in the lack of the active inhalation on the part of the patient, the air is still going in.
Oh,
So it's
I see.
actually getting into the lungs. It's actually the oxygen is getting released. Absorbed and released into the bloodstream.
So they're not losing.
They're not
any-
losing the actual inhalation part, which actually they for some reason in the apneic moment is actually lost. The inhalation and exhalation is lost.
So I know that people can be quite exhausted when they have sleep apnea. When they get up in the morning, I know a lot of times before they use the machine, before it's
Right.
diagnosed, say, I know
Right.
they get up and they're exhausted, even
Yes.
though they've been laying down for maybe 8 hours
Yes.
and supposedly sleeping.
Yes.
They wake up, and that's usually a sign that you would look for something like that, the sleep apnea.
Yes. It's a common question we would ask is, do you actually even feel rested after you've used your CPAP mask and your CPAP machine during the night? And that is the daytime tiredness and lethargy that is seen could maybe indicate adjusting the CPAP pressure or whatever it means, whatever it would take to build the right amount of pressure for getting the oxygen saturation accurately in the body.
So what are some of the other things? I know some of the other things that will, aside from sleep apnea, it could be pain could disturb someone's sleep.
Yes.
If they are in severe pain.
I would agree with that. Pain can actually interrupt sleep. And an adequate pain management would be essential. Most often times it means use of pain medications for that. So adequately controlled pain could actually improve sleep and actually even lead to less tiredness during the daytime as a persisting effect of lack of sleep. So it's just a lot of doctors are now concerned about the opiates that are being used for pain management these days because they have the abuse potential. So that does limit the ability of the patient to get adequate pain treatment management. But they can explain to the doctors that the pain is actually affecting my sleep and it's interfering in my day-to-day routine, my day-to-day functioning. Maybe they can consider, not to say that all of these only the opioids are pain relieving. Even the NSAIDs, the non-steroidal anti-inflammatory agents such as ibuprofen, Tylenol, adequate doses of those, naproxen are also good agents to manage pain. And those should be the first line treatment,
Right.
But patients with severe pain, may need, stronger pain medications.
Right, we have to do something more for them.
Right.
But I
right.
understand that the docs are being cautious these days, especially
Yes.
with all the publicity and the crisis that we're in with
Yes.
opioids. So we understand that. And the other thing that might get us up might be the bladder.
Yes.
So sometimes we would get up and then people cannot get back to sleep. Now they may have something in their mind and
Yeah.
that whatever is in their mind may just keep buzzing around there.
Yes.
And then they can't settle back into the sleep.
Yes, for that, a good suggestion I've read on is to limit fluid intake, oral fluid intake, meaning even water or juice or whatever, at least 30 minutes before you're planning to fall, planning to go to bed. So that would actually limit the urge to get up and go to the bathroom, But the second part of the concern you've mentioned is the difficulty falling back asleep, which could be hard for a lot of people because they might be thinking of something right before going to bed or falling asleep, or they might be thinking of something that was anxiety provoking or something they have to do the next day, so many things to accomplish or whatever, and that might keep them up. So another suggestion would be and my recommendation would be to just you know have a calm and relaxing environment, not think of planning your next day 30 minutes before actually going in bed, and just thinking of the most relaxing moments you've had, like a beach or some kind of a vacation spot. Yes, take yourself to or a picture or have an image in your mind of a pleasant thing before falling asleep. Maybe hopefully that will prevent the person who's actually gotten up to go to the bathroom to fall back asleep, I hope. There are medicines, of course, to help people stay asleep, but that's a separate topic. But we're talking more on sleep hygiene, but part of it is basically another thing I do want to mention is the use of smartphones and electronic devices, which is very common and so easy to have by the bedside and just look at it, Facebook, social media, Twitter.
How did we live without them? We can't miss one message. I have one friend that she's like glued to this thing.
Right.
And it's like, do you ever put that thing down?
I know.
And
it's tough.
we become addicted kind of to it.
It is, and
we used to live quite well without it.
Exactly.
And life went on, and we did okay.
I know. I remember those days too. But I do want to mention, like, shutting those electronic devices, especially the computer, the laptops, the smartphones, keeping them charged on or whatever. But just having them away from you may actually really be helpful. If you're sleeping next to someone, maybe talking about something nice, or a nice conversation might, or just to fall asleep, to initiate the sleep would be helpful also. It depends on the relationship with the partner, but
and breathing is not overrated, is it? We could sometimes take a few deep breaths, and that might help us relax a little bit.
Exactly. Yeah.
So there's a lot of anxiety out here.
Yes.
So people are nervous. We're nervous about everything.
Yes.
We're and we're in fear.
I know.
There's a lot of fear out here. We're afraid of failure. We're afraid of success. We're afraid of everything.
Right.
I'm not quite sure how we get to be such a fearful bunch.
Right.
But it seems that we are, and I think a lot of it is that we have this, because we're afraid, then we try to control things, which is only an illusion anyway.
Right.
The only thing we can control, I think, is the way we think and control our thoughts. But we can't control situations sometimes.
Yes.
Situations happen. Life happens, right?
Exactly, and it's so tough for us to just get rid of have that thought that things, we can't change a lot of things. Things would happen the way they are supposed to happen. And, we just have to take one day each day at a time, and so it's so easy to anticipate the disasters, the failures, and the anxiety that's like you said, related to the fears of things going wrong. And what if I don't do this? What if I don't get this done? What if I look like a fool? Something like that.
Perish that thought.
Yeah, exactly. So I think it's very easy, and there's a part of therapy. There's a kind of therapy actually. It's called cognitive behavior therapy, and it does focus on restructuring automatic thoughts like these, like negative thoughts. People just have this idea of jumping to conclusions. They think of the most negative thing that's going to happen to them, the most disastrous thing.
Anticipating and not participating, right?
Yes, exactly. And what people don't realize is that it's actually those thoughts and not the actual situation that's actually affecting their mood negatively. And if you challenge those thoughts, and you see how, even if they're an accurate thought that you've actually, and they call it like automatic thoughts, meaning that's this sudden thing that comes on, the most negative thing. And in therapy, the therapist usually focuses on challenging that thought and how accurate it is. And if it is not accurate, then what would be a plausible thought in that scenario, replace it with that plausible thought, and see if it makes you feel better, because really that thought was very negative, and it was the most negative, actually, all or none thinking, jumping to conclusions, negative filters. These are all examples of these negative thoughts. So typically therapy has actually proven helpful, even to improve sleep hygiene, even to improve people's anxiety related to the most negative, stressful situations they would be anticipating. So
let me say that the older population, they call us older adults now. They don't call us
Yes.
elder or seniors. We're all older adults. And the older generation,
uh-huh.
they, if anyone ever told us to go to mental health or psychiatry,
Yes.
they went with bags over their head because they were afraid that other people would think that
Right.
they were crazy.
Yes.
So now, as I say to these people, we have so many mental health professionals,
Right.
so many tiers of different professionals, and I say everyone, even psychiatrists need a psychiatrist now
Right.
and then, right?
Right.
So this cognitive behavioral therapy,
Uh-huh.
they might associate with some shame of
Uh-huh.
having to be part of that, a group like that,
Yes.
where we're trying to teach them a new way of thinking
Yes.
and responding, not reacting to things.
Right.
And but they might still be a little resistant. It's kind of a scary name,
It is.
cognitive behavioral therapy,
It is.
right?
I really like the notion of it. I think it's
I think you're right.
Right.
The concept is perfect.
Right. Right.
But, and which is why we're talking about it, so people
Right.
will understand what it is and
Yes.
how it can benefit them,
Right.
right? Take all that fear out
Yes. Exactly.
and all that shame that might be somehow associated with going.
Yes.
So typically you do that in a group?
There are cognitive behavioral groups, but ideally it's done on a one-to-one basis. So it depends on the therapist. A lot of therapists choose this modality for therapy. A lot of therapists choose other modalities. Interpersonal therapy and other modalities. But in terms of cognitive behavioral therapy, the more effective version for people who already are having a predetermined shame of seeing someone, I think initially, at least for the first few sessions, they should try the one-on-one individual therapy, because having overcoming the shame and just joining a group where other people are also suffering actually is a helpful situation, because they have the sense of universality. It's like cohesion kind of.
You're not alone.
You're not alone.
Yeah.
And so I think those. But to overcome that, I think we I
Start
think
with
that
the
we can.
one-on-one.
Yeah, I think they should start with the one-on-one. But it's pretty sad that people have had this shame and
Experience.
stigma about
I
mental
know.
illness, and it's just not like the automatic connection is like, I don't want to see a psychiatrist, they'll think I'm crazy. But really, what psychiatry and therapy also focuses on is anxiety, depression, bipolar illness, and even cognitive issues. We've been dealing, especially in the older adults, we've been dealing with people who've suffered from dementia, cognitive impairment, even delirium from medical or surgical cause. So we've actually been trained to actually focus and not only address it in terms of treatment, but also assign or delegate other members of the team, like if they need social support, if they need therapy, if there's need for more medication management in terms of getting someone, a visiting nurse at home, maybe they have trouble remembering to take pills, and so that's so we do collaborate with other disciplines in that regard. And so yes, I think it's a broader term, it's a broader connection with psychiatry and therapy to include all of these things. But yeah, especially for anxiety, and especially when anxiety becomes just not regular day-to-day anxiety, when it becomes a disorder, it's affecting someone's functioning, that's when the person should just, I think, keep the shame at the back burner and, approach for help. They can start with therapy if they don't
There
want
is
to see
no
a
shame
psychiatrist.
in asking for help, is there?
Yes,
There is no shame in asking for help.
Exactly.
We all need help once in a while.
Exactly.
I'm blessed to have the people in my life that have helped me
Yes. So am I.
along the way, and we all need that at some
Exactly.
point.
And all of us go through tough times,
Yeah.
We all can go through crises. And,
Exactly.
we need help, and we should know when to call for
Right.
help.
So let's talk a little bit about depression, because
Mhm.
here we are in going into the season of light deprivation,
Yes.
and we don't have, our day in sunlight gets shorter and shorter.
Yes.
I hate to see it happen.
Yes.
But it does. But then on the other side, it gets longer, so
Yes.
it's a cycle.
Yes.
Right?
It is.
But that does affect people, doesn't it?
It does affect people, especially in the older adults. When people with cognitive impairment, we've seen, a phenomenon called sundowning,
Oh,
when
yes.
the behaviors actually, with patients who have dementia, they tend to have more behavioral problems, and they get more agitated. They get, sometimes more paranoid around the time that sunset, is going on, like around, pretty much dusk time.
So whether they realize that the sun is setting or not, right?
Exactly, yes.
It's irrespective of
It is
that,
irrespective, I would say. Yes,
Yeah.
you're right.
which is fascinating, isn't it?
It is fascinating, and we tend to dose medication to help them accordingly, and sometimes even get more. So environmentally, I think getting more, light therapy is also an indication here,
Right.
where people not
They
only
have special lights.
they have special light boxes
Mhm.
these days, especially for people with there are two things, if you, for people, for patients for dementia patients with sundowning phenomenon, I don't think we've put light boxes into use yet, but we usually are managing the behaviors around the time it's happening, but ideally I think even on the inpatient or the nursing home setting, I think they can have more brighter lights, if that is the cause of the behavior. However, there's a phenomenon called for adults with with adequate cognitive functioning, I should say. Some adults cycle through this. It's called seasonal affective disorder.
Right.
In the winter months, they have this long periods of depression, directly tied into the weather. Not the weather, but the lack of sunlight, I should say. And there's this a light box, that is available, I think, also on the internet,
Oh, yes.
through Amazon, and also on typically insurances, I think, nowadays covering it if you have a doctor's prescription through the pharmacies. But
That's
they
good to know.
yeah, they I mean, if you get a prescription for that, I think, I'm pretty sure it'll be covered. But I think the best way to use it is during the daytime, sitting and reading something, a magazine or a newspaper for about 30 minutes to an hour underneath that light box. So the light box is right above you, and you're reading something below it, and that's actually a scheduled pattern, like from 10 a.m. to 11 a.m. The patient is doing that every day.
And that,
That actually has been shown to be effective for seasonal affective disorder,
wow.
which is a some sort of depression. Now, seasonal affective disorder could be also the bipolar type for patients with bipolar illness. People
That's
have
a little more
That's a
complicated.
little more complicated. You're right. However, with this kind of treatment, I think the light therapy box has been shown to be helpful and effective. So, but the key here is, underneath that light box, you're not supposed to take a nap. If your eyelids are shut, it's really not reaching the retina, so it's really not being effective in that way. So you're actually supposed to read something
Stay
during
awake.
the duration that the light box is on. So
Right, to get the benefit.
to get the benefit, yes.
That's an important point.
Yes.
I didn't know that.
Thanks.
That's why we do the show.
Yes.
So we have a few more minutes here.
Mhm.
So there are, of course, there are other kinds of depression that people go through.
Yes.
And so what are the recommendations? You mentioned a couple of things, and coming together with people is an
Right.
important thing. That could work for you or against you,
Yes.
depending on the people.
Exactly.
Right? So
yes.
you want to go to positive, upbeat people.
Yeah.
And again, that sends the message to us that we're not alone, right? That
Right.
we're not alone.
Exactly.
That other people care about us, and
Right.
and if we were missing, then someone would care about that.
Exactly.
That's an important thing for us
Right.
as human beings. But isolating is, I say, always the biggest enemy of older adults.
I agree. Yes.
Yeah.
Especially if the older adult has had a significant loss, like a loss of a spouse, someone they've lived with for so many years. It's very tough, and those are the older adults who tend to isolate a lot. So it's very tough for them to actually, for us as treatment providers, to make a change in their life and encourage them to attend a day program, or some kind of an activity like where they can socialize with similar people in the similar age group. They have older adults at home also have ride issues. We will also, when we're making these plans, try to get them transportation.
That's a big one out here.
Yes, because that's been the most common reasons that we don't show up on the day in their day programs. And also, some of these older adults have their afternoon medications to take, and during if their time of the day is actually they're spending the time there, if their nurse is well and good at the day program, but someone has to keep track of the afternoon medications that are due. So those are some factors that might help. Actually a recommendation that might help with people who are isolating, because of the depression, and making this change for them to go out and interact. It has to have, first of all, it should be a positive experience for them to continue and persist doing that. So.
Okay, well, thank you so much
You're very
for
welcome.
coming on the show.
You're very welcome. Thank you. It's my pleasure.
Yes,
I
thank you.
enjoyed being
and
here.
We'll bring you back again. Thank
Okay,
you so
sounds
much.
good. Thank you so much.